I'm Dr. Stephen Goldstein of the New York University School of Medicine, and the topic that I'm going to present to you is entitled The Use of Ultrasound in Perimenopausal and Postmenopausal Bleeding. These are my disclosures. I've done a lot of things for different areas in the pharmaceutical and medical device company. My learning objectives, I want you to understand ultrasound-based triage for women who have abnormal uterine bleeding, the shortcomings of blind endometrial sampling, appreciate indications for saline infusion sonohysterography, or what we call SIS, and optimize the technique of saline infusion sonohysterography, or SIS. My lecture outline in brief, first we'll go through some normal endometrial anatomy and physiology. Then I'm going to talk about some definitions and the demographics of bleeding. Then specifically want to talk about the role of transvaginal ultrasound. We'll talk about the role of saline infusion sonohysterography, cover some of the ultrasound limitations, give you some tips to enhance the success of sonohysterography or SIS, and finally talk a little bit about the latest recommendations from ACOG, American College of Obstetricians and Gynecologists. As I've already alluded to, successful use of ultrasound in patients with bleeding, I think, begins with a short lesson in pathophysiology. Ultrasound findings in general, and especially here in the endometrium, will simply reflect what is present or not anatomically. So what are the normal or expected findings? And obviously, I think this will depend on what hormones are present and when they are present or potentially absent. So realize that the endometrium consists of a basalis and a functionalis. Estrogen causes the functionalis to proliferate. Proliferative endometrium is characterized by abundant mitoses. And I want you to look at the amount or height of the tissue. This is now a hysterectomy specimen taken from a patient in the proliferative phase. You see all these glands have abundant mitotic figures. You can see the relative thickness of this endometrial surface. And if we look at this long axis view of an ultrasound of a patient in the proliferative phase, we see this midline echo, which represents the interface between two sides of the endometrial cavity. The basalis is out here, and the two sonolucent areas here represent the functionalis in the proliferative phase when the glands are well lined up towards each other. Progesterone, or in the case of sequential hormone replacement therapy, the use of a progestin, will convert this estrogen-primed endometrial functionalis to a secretory phase. Secretory endometrium, the glands will line up in a linear fashion, and this results in a fiercely echogenic appearance on ultrasound. So notice the glands here in the secretory phase are all somewhat linear. And what happens is, if we look at this as a transvaginal ultrasound, this is now the uterus and long axis. Here's the endocervical canal leading up into this fiercely echogenic endometrial echo, which corresponds to the secretory phase for the introduction of progesterone. After shedding of the functionalis, the basal endometrium that remains is initially quite thin and will appear as such on transvaginal ultrasound. So if we look at the postmenstrual endometrium, it's left with a little bit of functionalis. The basalis is predominating here. And if we look at this sonographically, seen here on day 5 of the cycle, you can see a thin, distinct endometrial echo representing the interface between these two layers of what's remaining of basalis, and there's really not time yet for development of this estrogen-primed functionalis. So in menopause, there is no estrogenic stimulation of the functionalis, and the endometrium is in fact atrophic. Atrophic endometrium is characterized by simple tubular glands. They lack mitotic activity. The stroma becomes fibrotic, and there's increased collagen fibers. And so if we look at this menopausal patient, there's basically a single layer of low cuboidal epithelium here but there's really no development of the functionalis, no estrogen stimulation. And if we look at this sonographically, this thin white echogenic line is the interface between two sides of basalis inactive endometrium. So since there's really no normal width of endometrial thickness, what would be the proper use of the endometrial echo on transvaginal ultrasound as we want to think of it clinically? And the answer is the high negative predictive value of a thin distinct echo in patients with bleeding. Now, it's essential that you realize this is in patients with bleeding. Well, postmenopausal bleeding is not so easily defined. I mean, menopause is the final menstrual period, and obviously it's a retrospective diagnosis. A woman never knows that the period she just got is the last one she will ever get. So another definition is no bleeding for 12 months due to a depletion of ovarian follicles. And understand that if you do get a serum measurement of an follicle-stimulating hormone or estradiol, these can be notoriously unreliable because that's just a snapshot of ovarian function at that time. The erratic function of the ovaries in late perimenopause often makes it very difficult to label somebody's bleeding as being definitively postmenopausal, but it may not really matter because we know from third year of medical school that a postmenopausal bleeder is, quote, endometrial cancer until proven otherwise, and this mandates evaluation. But the ACOG Practice Bulletin from July 2012 mandates that endometrial assessment to exclude cancer is indicated in any woman older than 40 who's suspected of having abnormal uterine bleeding. So it may not be so crucial to establish if a particular woman is in late perimenopause or truly menopausal, because if she's got abnormal uterine bleeding, she's going to need to be evaluated. 1/3 of all visits to the gynecologist are for abnormal uterine bleeding, and 70% of GYN consults in the peri and postmenopausal years are for bleeding. Of perimenopausal women with abnormal bleeding, roughly 80% will have no endometrial pathology. In other words, their bleeding is dysfunctional and anovulatory, what some doctors will tell them is hormone imbalance. The other 20% may have an anatomic reason for their bleeding, and we'll get into that. In the postmenopausal women who bleed, what we call PMB, 3 to 7% will have endometrial cancer. The range is actually 1 to 14% if you look in the literature, but most studies place it at about 3 to 7%. The majority of postmenopausal bleeding, however, is secondary to atrophic changes. So I've kind of already alluded to the fact that there's this great divide. You've got somebody with abnormal bleeding or postmenopausal bleeding. Either there's an anatomic reason, polyps, myomas, hyperplasias, even frank cancers, or there's no anatomic reason, in which case the bleeding is dysfunctional and anovulatory in premenopausal women and often atrophic in postmenopausal women. So ultrasound cannot make a histologic diagnosis. As we've stated, its greatest contribution will be the high negative predictive value in a thin, distinct echo in excluding cancer, as well as the ability of saline infusion enhancement, or SIS, to distinguish a global from focal process, and I'll develop this. So what's the data? Well, this began in the early 1990s. Transvaginal ultrasound was utilized in women with postmenopausal bleeding to see if it could predict which patients lacked significant tissue and could avoid a DNC or endometrial biopsy and its discomfort, expense, and risk. Consistently, those early observational studies, the finding of a thin, distinct endometrial echo less than or equal to 4 or 5 millimeters was shown to effectively exclude significant tissue in postmenopausal women with bleeding. And these were some of the early observational studies we published in 1990, Varner in 91, Gramberg in 91, but these were all just small observational studies. Then a series of large prospective studies from Western Europe were collected on postmenopausal women with bleeding. And the Nordic trial, published in 95, out of 1,168 women who had an endometrial echo less than or equal to 4 millimeters, they had no cancers. Enrico Ferrazzi in Italy, 930 women less than or equal to 4 millimeters, 2 cancers, less than or equal to 5 millimeters, 4 cancers. Barrett Gull, Elizabeth Epstein, Barrett Gull in Scandinavia. If we look at a composite of all of these prospective trials on postmenopausal women with bleeding, for an endometrial echo less than or equal to 4 millimeters, the incidence of malignancy was 1 in 917. And so in February of 2009, ACOG's committee opinion then went on to state, when transvaginal ultrasound is performed for patients with postmenopausal bleeding and an endometrial thickness less than or equal to 4 millimeters is found, endometrial sampling is not required. And that was a real change in paradigm. So what is this based on? Well, should you even still do a biopsy? The false negative rate of a transvaginal ultrasound less than or equal to 4 millimeters, we said, is 1 in 917, much less than a negative suction piston biopsy. And in fact, this paper showed that if you do an endometrial biopsy on postmenopausal patients with an endometrial echo less than 5 millimeters, only 82% of the time was it even successfully performed, and of those, only 27% gave tissue sufficient for histologic diagnosis. And so this 64-year-old woman who has a stain in her underwear comes into my office. I do a transvaginal ultrasound. I see the endocervical canal. I see the endometrial echo taking off from the endocervical canal. And I see this fine white distinct line. This excludes significant tissue. This woman has no significant pathology and needs no further workup. In premenopausal women in whom the endometrium undergoes cyclical change, timing is obviously crucial. As the endometrium proliferates, it is not always topographically homogeneous. Secondary to previous deliveries, D&Cs, cesareans, myomectomies, etc. And so here's a woman where a sonohysterogram was done in the secretory phase. Look at the irregular topography of this woman's endometrial cavity. It is not always homogeneously topographically smooth. So we published an algorithm of transvaginal ultrasound and saline infusion enhancement that we proposed and tested prospectively. It's really not an oh my god slide. What we did in those days was a vaginal ultrasound on day 4 to 6. If we saw a thin, distinct endometrial echo less than or equal to 5 millimeters, and these were now premenopausal patients, we made a diagnosis of dysfunctional anovulatory bleeding. If the central echoes were thickened, greater than 5, or we could not see an echo adequately, then we went to saline infusion sonohysterography. And this then gave us our 3 buckets. Then with saline infusion, we could either see that the endometrium was thin, less than 3 millimeters each layer, because realize we separate the layers with no focal abnormality, and thus we would diagnose dysfunctional anovulatory uterine bleeding, and your workup was done. If we saw symmetrically thickened endometrium, then we felt a blind office biopsy was appropriate. But if there was a focal lesion or asymmetric thickening, then we did D&C hysteroscopy and would do this under direct vision. We had 433 patients. They were perimenopausal. The average age was 47. They either had menorrhagia, metrorrhagia, or both, what we now call abnormal uterine bleeding. Of the 433 patients, 280 had a endometrial echo less than or equal to 5 on day 4 to 6. 153 went to saline infusion sonohysterogram. Of those, 44 were for non-visualization of the endometrial echo, and 109 or 71% were for an endometrial echo greater than 5 millimeters. So remember, we started with 433 patients. About 44 of them, we could not see an endometrial echo. Well, here's some examples from that study. Here's a woman on day 4 to 6. She's got a 2 millimeter endometrial echo, and this excludes significant tissue, and her bleeding is dysfunctional and anovulatory. Here's a woman who's got an obvious myoma. You can see some of the endometrium being distorted by it. Is she a candidate for resection? We put some fluid in here, and you can see that the myoma ends here, and from the back of the myoma to the serosa was 12.5 millimeters. So there's plenty of room and safety to do an myometrial myoma resection. Here's a more modern clip of a patient like that with a very heterogeneous thickened endometrial echo early in the cycle. We do saline infusion, and you can see she's got a rather large polyp with a central feeder vessel here, and the endometrium surrounding the fluid is in fact thin because this is done early in the cycle. So our results of these 433 patients were about 79% had dysfunctional anovulatory bleeding, about 5% had submucous myomas, although fully 1/3 of them had fibroids, but only 5%, not 33%, had a submucous component. There were 13% that had polyps, of which 3 were endocervical, and there were 15 or 3.5% had hyperplasias, of which 5 were symmetrically thick, 4 were focally thick, and 6 were in polyp. Now, when we looked at these hyperplasias, these were too small numbers to be statistically significant, but the trends were in the direction that you would have predicted them. In other words, of the symmetrically thick endometria, 4 out of 5 were simple hyperplasia. Of the focally thick, 3 out of 4 were complex hyperplasia. And of the hyperplasias in polyps, half were simple and half were complex. A blind endometrial sample, PIPELLE, could have missed up to 79 non-global lesions. That's 18% in those patients that had focal abnormalities like polyps, submucous myomas, or even focal hyperplasias. So why is there an issue with blind biopsy, i.e. PIPELLE? Well, this paper by Tom Stovall in 1991, what did Stovall do? He took 40 women with known carcinoma. He did a PIPELLE the week before their hysterectomy in the clinic. He got cancer in 39 out of 40 patients. Thus, he said the accuracy was 97.5%, and this was widely publicized. All of the throwaway journals, Contemporary OBGYN, Female Patient, OBGYN News, full page ad every month. PIPELLE, 97.5% accurate. Rodriguez also studied this. He did prehysterectomy sampling with both PIPELLE and Avabra. What used to be the standard before PIPELLE was a re-sterilizable suction tip attached to a machine that was relatively painful, sort of like an in-office DNC. PIPELLE sampled an average of 4% of the endometrial surface area, range 0 to 12% versus 41% for Avabra. PIPELLE agreed with post-hysterectomy diagnosis in only 84% of cases. This paper by Guido, though, is really important to review. Guido basically did the same thing that Stovall had done, except he took 65 patients, not 40, with known carcinoma of the endometrium. He did his PIPELLE under anesthesia prior to the hysterectomy. They missed 11 out of 65 cancers. That's 16%. But he did us the favor of opening the uterus. And of the cancers they missed, 3 of them were less than 5% of the surface area, 4 were less than 25%, and the other 4 were less than 50%. And of 11 tumors in polyps, they missed 5. None of what they missed had greater than 50% of the surface area involved. So the authors concluded PIPELLE is excellent for detecting global processes in the endometrium. Very important, global processes. Other people did something similar to Stovall and Guido. These were PIPELLEs done in patients with known carcinoma. In this study, they missed 7%. In this study, they missed 17%. In this study, they missed 33%. This is patients with known cancer. Not nearly as reliable as the original work by Stovall, and yet no full-page ads in the journal saying, PIPELLE, 67% reliable. The study that we presented using ultrasound-based triage in perimenopausal women resulted in 65% of women being able to have an ultrasound exam only, done at the right time of the cycle. Another 17% got sonohysterography, either for a thick endometrial echo or inability to see it. Only 2.3% got PIPELLE biopsy for a proven global process, and about 16% went to the OR for DNC hysteroscopy, but for proven anatomic pathology. Well, and very early in my experience of doing this, one of the nurses in our ambulatory surgery unit said to me, Dr. Goldstein, how come all your patients have something? I got a tiny bit paranoid, and I said, what do you mean? And she said, well, today you did 2 cases, both had polyps. 2 weeks ago you were here, there was 1 polyp and 1 fibroid. But your patients always have something. When the other doctors come here, often they have something, but a lot of the time they don't. And I said, that's because you never see the patients who have nothing. We can diagnose nothing very, very accurately upstairs using ultrasound and saline infusion sonohysterography if necessary. So ultrasound does not give us a tissue diagnosis. The value of ultrasound and sonohysterography is the ability to triage patients to either no anatomic pathology, a global endometrial process, which then gets a blind biopsy, or a focal process, which needs to be done under direct vision. There is a crucial caveat. Not all uteri lend themselves to a meaningful ultrasound evaluation of endometrial thickness. Things like adenomyosis, coexisting myomas, the axial uterus. People used to think the retroverted uterus was problematic. The closer to a right angle the beam of sound is to the structure you want to study, the better you will see it. Marked obesity, previous surgery. And so here's an example of a patient who's got some bleeding. I don't see an endometrial echo. This woman's got some significant adenomyosis. You can't find an endometrial echo on this patient. Or here's another example. You see a little bit of what appears to be some endometrial echo here, but this is being totally obscured. You cannot use this. If you see something like this, you must go to saline infusion sonohysterography. You should think of saline infusion as a subset of transvaginal ultrasound when you cannot adequately visualize the endometrial echo, or you see it well, but it's not thin enough to exclude pathology. And here's yet another example of a patient with adenomyosis. There's a hint of some endometrial echo posteriorly here, but nothing that I think you can be reliable to exclude pathology. And recall that perimenopausal bleeding study that I told you about. Remember, we said there were 433 patients. 44 of them had sonohysterography for non-visualization. This was in perimenopausal women. Thus, 10.2% of perimenopausal women with abnormal bleeding had an endometrial echo that was not adequate to be used diagnostically without saline infusion. And in such cases, the SIS will enhance the transvaginal ultrasound. As I said, sonohysterography is thought of as a subset of transvaginal ultrasound when the endometrial echo is not thin enough or it is not well visualized. Go into a little detail about the sonohysterogram. It's using fluid installation to enhance ultrasound detail of the endometrium. We know that fluid enhances sound transmission, so these will be among the easiest ultrasound exams you will ever have to perform or interpret. I mean, the reason ultrasound is such a home run in obstetrics is the baby's in a bag of water. Fluid is your friend. It enhances sound transmission. The technique of sonohysterography is relatively simple. I do a pelvic scan in an unenhanced baseline mode. I still do a palpatory bimanual exam, although increasingly you can tell if the uterus is anteverted or retroverted by your ultrasound. Put the speculum back in. I clean the cervix, usually with a betadine type solution, and then I thread my catheter in, being sure to flush the air out first. Take the speculum out. I say here carefully because I still haven't invested in single-hinged specula. I reinsert the vaginal probe. I like to use 10 cc syringes, but whatever you're comfortable with. And as I'm instilling sterile saline, I will watch the screen, being sure that I scan from cornua to cornua, and then turn 90 degrees and scan down towards fundus, up towards fundus, and down towards cervix. And if I've got 3D capability, I will make a 3D sweep so I can go back and look at this in the future. Tips to fine-tune success for sonohysterography. Well, it is very important to realize you must do 3D reconstruction, either with 3D or with your head, because every one of these single frozen ultrasound images is a two-dimensional snapshot. So a single long-axis view of a seemingly normal endometrium does not rule out pathology. The entire structure's got to be observed and three-dimensional anatomy recreated. So here's an example where in some of these planes, you'll see in a moment, this looks relatively normal, but as we move over, you can see there's a large myoma. So in an unenhanced mode, in one snapshot, two-dimensional view, this might have been interpreted as being normal. Sometimes you can't thread the catheter. What happens then? Well, if you change the position of the speculum, it often will change the angle that the cervix makes with the corpus, and the catheter slides right in. If not, I use a cervical stabilizer. And this is a very, very fine-toothed tenaculum, and as a last resort, I might use a small number 13 Pratt dilator. This is a single-toothed tenaculum. It is a weapon. It causes pain. It causes bleeding. This is a cervical stabilizer. It is a wisp of an instrument. It has one notch on the ratchet. It doesn't cause pain and bleeding. It's a little bit like saying you need a shot. Do you want it with a 14-gauge needle or a 25-gauge needle? Sometimes you can't really distend the cavity. Well, it requires very little fluid to outline the cavity, and sometimes you have the same problem in hysteroscopy. Some cavities are more difficult to distend. You want to check the position of your catheter, but even a little bit of fluid will enable us to see that this woman has symmetrically thick endometrium anterior and posterior wall, and so she can have a blind biopsy and turned out to have simple hyperplasia. This is a very important caveat. The procedure is very time sensitive. It must be done on the last days of staining or the first few days after the bleeding cycle ends, when the endometrium will be as thin and uniform as possible. I've already alluded and shown you that as the endometrium proliferates and thickens, it is not always perfectly symmetrical. You must be aware of this endometrial heterogeneity, sometimes referred to as endometrial moguls. So here's a woman who's 18 days from her last bleeding episode. And we put some fluid in there. You can see some of it twirling around. You know, is this focal hyperplasia? Is this a small polyp? This is the kind of heterogeneity you can see in a normal patient. Here's another example of a sonohysterogram done at the inappropriate time of the cycle. Look at the marked topographic heterogeneity. And here's a clip. You're going to see what looks like a small polyp here posteriorly, but in reality, this is just typical heterogeneity later in the cycle during saline infusion. So it is absolutely crucial you do this at the right time of the month. You want to avoid sonohysterography with active bleeding. This is a little polyp. I'm sorry, not a polyp. This is a little blood clot, which would be mistaken for a polyp. Look how thin the endometrial lining is on the sonohysterogram. And here's just a piece of tissue that hasn't really worked its way out yet. Or another example of just some debris and blood or clot, which is not totally gone yet. You see the endometrium surrounding the fluid is in fact nice and thin. Sometimes these patients are bleeding so much or so often, you can't really tell what's a menses. And so consider an empiric course of a progestin, what my teachers used to call a medical curettage, to slough the endometrium and then time your sonographic evaluation to the withdrawal bleed. You want to avoid getting air into the catheter or the syringe because air is very echogenic. So if you squirt air into the endometrial cavity, it becomes very difficult to see anything. And here's another example of inadvertent squirting air in here. You obscure your ability to see. Air is gas, and as you know, gas is our nemesis, just the way fluid is our friend. So back to the ACOG practice bulletin of July 2012. They tell us the primary imaging test of the uterus for the evaluation of abnormal bleeding is transvaginal ultrasonography. They tell us that if transvaginal ultrasonographic images are not adequate or further evaluation of the cavity is necessary, then sonohysterography, also called saline infusion sonohysterography, or hysteroscopy, preferably in the office setting, is in fact recommended. It does say that an office endometrial biopsy is the first-line procedure of tissue sampling in the evaluation of patients with abnormal uterine bleeding. Endometrial biopsy has high overall accuracy in diagnosing endometrial cancer, but look at this. When an adequate specimen is obtained and when the endometrial process is global. If the cancer occupies less than 50% of the surface area of the endometrial cavity, the cancer can be missed by a blind endometrial biopsy sample. And as we've already alluded, this is all based on that wonderful study from Guido, where they missed 16% of cancers, but they were all less than 50% of the surface area. PIPELLE is excellent for detecting global processes in the endometrium. The ACOG bulletin goes on to say that a positive test result is more accurate for ruling in disease than a negative test result is for ruling it out. These tests are only an endpoint when they reveal cancer or atypical complex hyperplasia. Let me repeat that. That is a sea change. These tests are only an endpoint when they reveal cancer or atypical complex hyperplasia. So sure, you can start with an endometrial biopsy, but if it is negative, the patient is bleeding, you have not completed the evaluation. So now that the standard of care corroborates that a negative blind biopsy is not a stopping point, clinicians can still begin with the biopsy, but unless it's malignant or complex atypical hyperplasia, the endometrial evaluation is not complete. So, in summary, we talked about understanding the causes of bleeding in perimenopausal and postmenopausal women and how that allows us to better understand how to use our transvaginal ultrasound. We talked about the great divide between anatomic and no anatomic pathology. We talked about how a thin, distinct endometrial echo excludes significant anatomic pathology, that sonohysterography, or SIS, is a subset of transvaginal ultrasound when the echo is either not thin or not well visualized. That transvaginal ultrasound and sonohysterography are very time-sensitive in patients whose endometrium cycles and should be performed just as the bleeding cycle ends. Transvaginal ultrasound is the first step in the triage of abnormal bleeding and postmenopausal bleeding, and when done properly, will reduce any further invasive procedures in the majority of patients. And here are some references if you want to go back and read more about some of the things that we've talked about. And I thank you very much for your attention and hope that you have found this valuable.